Okay, I've been holding you back now for a few minutes on what we really would like to discuss. That's new at this year's ASCO meeting here in Chicago, and that is the use of Venetoclax in combination with an anti-CD20 antibody in previously untreated patients. Why don't you discuss a little bit about the use of Venetoclax in those previously untreated patients?
So we are very eager and expecting the results from this trial, because we knew that it was already finished and we knew the results. We didn't have the opportunity to see them at the ASH meeting, but now finally we are going to be able to, well, it was this morning, was presented, right? So there was an initiative from the German group. This is called the CLL14. The German group, as you know, has always been in the front for any kind of trial who address the needs of patients. So the first trial that really start to target the older population, as CLL14 does. Older population, more than 65, comorbid conditions, CR score more than 6, or younger with comorbid condition. So the classically patient that we really encounter in our practice. So the trial really tried to address the use of Venetoclax in combination with a second generation monoclonal antibody, such as obinutuzumab, against the classical combination of obinutuzumab, chlorambucil, very, very well studied and very well reported as good data in the older population.
So it's the same kind of population that led to the approval of chlorambucil with obinutuzumab.
Absolutely. So I think it's very, very important to point it out that the goal of the study was in the classical CLL population, older patient. We know historically, the very beginning, chemotherapies, strategy, chemoimmunotherapy were applied to younger population, but we know that this is really only 1/4 of the patient. So the real patient with CLL is the older with multiple comorbid condition. And this is what really this trial is trying to address. And as you really already read, you know, it's an extremely superiority instead of PFS when we compare really these two really arms, favoring the Venetoclax obinutuzumab arm. Once again, what is being reported by the German group, obviously in this ASH, is that very, very high levels of MRD negative done by many methods, as PCR or even next generation sequencing, with levels that really comes almost to the 70% range, which is something historically very, very important. So once again, we start to define that this not only complete response, overall response, and now we're introducing this MRD negativity in the bone marrow, because it's a very, very important predictor of long-term outcomes in terms of PFS. And this is what this trial is showing. The last thing that is showing, obviously, is limited therapy. And we are discussing about 1 year of therapy in both arms, but at 1 year of therapy, patients stop therapy and they're being followed until progression.
Help me understand something. I remember some of the earlier Venetoclax data with rituximab, and the rituximab was added after Venetoclax. In this study, obinutuzumab started and then Venetoclax. Why is that?
Excellent point. So what you're referring is that the Murano study, they use Rituxan and Venetoclax at the same time. So again, you know, we were really discussing about the myth of the TLS that is not really very well seen in the real life, but it was reported in the early studies. I think with this trial, in order to really make people more comfortable, what they're being done is to really debulk the disease with an antibody as obinutuzumab to really lower the amount of circulating CLL cells or even large lymphadenopathy, and then after three doses, right, start to really do the ramp up of the Venetoclax. Again, we'll discuss if it's necessary or not. You can do at the same time, but definitely really downgrade most of the patient who has high or intermediate risk to really lower risk of TLS, which really have these important consequences, because we now intermediate and low can be managed as outpatient, while high risk, it needs to be monitored more closely.
And in fact, in the CLL14 trial, if I remember from the presentation or the abstract, I can't remember, but the TLS was actually seen during the obinutuzumab phase, correct, and not afterwards when Venetoclax was
That's correct. That's a very, very important. We always talk about TLS, and we are doctors, and we love to really see TLS, because it's what we really want. It has to be managed,
but we want to see it.
But we want to see that. What's really very interesting that we knew for years that obinutuzumab produced TLS, but no one look at that. So I have a patient who have 400,000 with the first dose, 100 milligrams go to nothing. So it's impossible those patients don't have TLS. It has a TLS that is being managed by the organism. I think with this trial showing that obviously you can see some evidence of TLS that is relatively easy to really manage with hydration and with prophylactic measure in the first phase, because it's what these patients need to be debulking.
Well, ancient history with rituximab as a single agent,
Absolutely.
It was like 5% TLS.
Absolutely, absolutely.
Okay. How about, now, is P53 really an issue in the frontline setting, though? It's only like 5 to 10% of the patients have it, is that correct?
It's 10% by
10%.
FISH, but you can add a 4% by sequencing. So around 15% is we can really put together both things.
Okay. So in terms of the future, tell us a little bit about combinations. Can Venetoclax be added to, BTK inhibitors, PI3 kinase delta inhibitors?
That's for sure is the future. As you may hear recently, a publication in the New England Journal by the MD Anderson Group, Tim Jane, really already incorporate this concept. A concept that, by the way, has been studied in Europe, in the UK group, and also in a randomized trial that using ibrutinib venetoclax against obinutuzumab chlorambucil, a trial that has already been enrolled, and now we're going to start to watch. So I think it's bringing the next frontier of how we're going to use these target drugs. I was mentioned to you in the beginning that we really characterize as BCR signaling and BCL2 upregulation as the two main reasons why cells proliferate and survive. So it makes sense to combine both things to really achieve very high rates of MRD and responses, as MD Anderson Group show in this paper. So I think it's something that we're going to really see more and more in the future, because we always say that the medicine is always really divided between the people who want to use the best drug in the front line or the people who want to really save something in the back of the pockets. Yeah. But there is no doubt that I think it's a great opportunity to investigate this trial that has very remarkable data in the front line, so many groups, but we still need to really see how this data is going to pan out in randomized clinical trials.
And in the NCI-sponsored intergroup trials, Alliance, ECOG,
Absolutely.
We are looking at triple combinations.
Triple combination.
Yes, with anti-CD20, BTK inhibition,
the triple combination is something that is also been studied and is very interesting. I just wonder how much we need to do to really eradicate it and how much damage we're going to really produce in terms of infections, neutropenias, and things like that. It's something that we should be very careful about that, because obviously we have the best of the world, right? The anti-CD20, BCR inhibitors, BCL2 and BTK inhibitor. But we need to really be very, very careful how we stratify, how we really sequence these drugs in the way that we don't produce too much toxicity and patients have really, really great outcomes.